ma'am, for the introduction. And really, though the hall is empty, but I'm actually thrilled because from where I started my journey in 1998, coming from Shamnagar, place from where probably nobody was there in medical college. I was the first person from that particular place, and after that, this journey to now what I am. Now I am working in the Department of Nephrology, IPGMER, doing transplantation. Last we did ABO incompatible transplantation, first of its ever kind in government setup. That I took the initiation and ultimately we did it. And so this journey actually started from here, and whatever I learned, that actually is from here. The courage and the enthusiasm for doing any work, that I learned from here, and the teachers and those who were there. And I must congratulate and thank Ovik and everyone for organizing this spectacular reunion, probably first of its ever kind in 190 years history. So this topic is actually probably a complicated topic, osteoporosis and CKD, but why I just mentioned or are trying to say something about this, because it is actually not discussed anywhere in any place, in any forum, though it's a medicine or in surgery or nephrology or endocrine, because osteoporosis in CKD is a neglected one. But osteoporosis per se, which is defined as a fragility fracture, the bone becomes very much fragile, and so you will have a fragility fracture. A trivial trauma can have a fracture, maybe in the hip, maybe in the spine, maybe in here in the body. So the patient, the person can be disabilitated, bedridden. So this is very, very important. And this is actually rising throughout the world because of the life expectancy that that is gradually increasing, and now we can expect around 80 to 90 years of survival. And so the bones becomes porous because of the age per se, and so this is gradually increasing, and India is even not the exception. Particularly the rural population is again very much prone to develop this one, which is a misconception that the rural population is not suffering from osteoporosis, but around 100 million people per year is actually suffering from this osteoporotic fracture every year in India. And if you see, there is a osteopenia prevalence is 52% and osteoporosis 29%. It is much higher than the counterpart developed countries. And this is actually the changes that occurs in the bone. That bone becomes porous, that is, there is a decreased bone mass, there is decreased trabecular thickness, then the other component of the bones are actually getting very less, so bone becomes porous. So this is a normal bone, and after that, then the osteoporosis, there is a moderate osteoporosis. You can see that the porosity is increased, and if you see the gross osteoporosis, the severe osteoporosis, there is nothing left as a mineralization in the bone, and so ultimately it is a fragile bone. This is severe osteoporosis. So there are some modifiable risk factors, that non-modifiable risk factors. I have already mentioned that age, the increasing age is the predominant factor for the osteoporosis. Like female sex, the maternal family history of hip fracture, low birth weight, disease predisposed to osteoporosis like Paget's disease, which are non-modifiable risk factors. So the potentially modifiable risk factors are very, very important, particularly the addiction like smoking, alcohol. Then the dietary calcium and the vitamin deficiency. These are the very common thing that we can easily modify so that the osteoporosis can be prevented. Then if you look at this particular picture, there you can find that the vertebral fracture are actually increased after age 50, particularly in the women. And the disc fracture, which is common in the younger age group, that becomes plateau. So if the vertebral fracture and the hip fracture increases, ultimately what happens? The person becomes bedridden. So that is the most important thing, that we need to prevent this osteoporotic fracture. Otherwise, the quality of life will be hampered, as well as the mortality will increase. And here comes the relationship between the CKD and the bone health. Now CKD is another very important aspect. This is probably again very, very less discussed. The CKD is a very important cause for bone disorder, and that bone disorder is called CKD-MBD syndrome. And this CKD-MBD, that is mineral bone disorder syndrome, is defined as a combination of three particular entities. One is the biochemical abnormality, which includes the calcium, vitamin D, phosphate, intact parathormone metabolism defect. Next is the abnormalities in the bone turnover. That is, either it could be high bone turnover disease or it could be low turnover bone disease. and there is extraskeletal manifestation. That is extraskeletal calcification. Here in this picture you can find that there is a calcification in the abdominal aorta, and it is now proved beyond doubt that when there is calcification in the major arteries, that calcification also involves the cardiac arteries, and there is high chance of cardiac morbidity and mortality, and that is the most important cause of sudden cardiac death in the CKD population. So this also involves in the bone metabolism and bone mineral metabolism. So this is very, very important aspect, as we are actually having more and more number of CKD patients throughout the world as well as in India. And if you see a particular area where 100 population is there, out of this 100%, at least 10 are suffering from CKD. That we actually don't know, and out of them, there are significant number of osteoporosis there, and the fracture that is also interrelated with this particular entity. So this is very, very important aspect, that we should have a awareness about the CKD and the CKD osteoporosis. That's why I took this topic to discuss over here. I am not going in detail, in depth about this, but there is, as the CKD advances, the CKD stage 3 crosses, there is increased chance of this CKD MBD, and there is a problem with the osteoporosis and the CKD MBD. Now there is a particular difference between the CKD MBD and the classical postmenopausal osteoporosis. Like in osteoporosis, postmenopausal osteoporosis, you will not have significant abnormality in the calcium, phosphate, vitamin D, IPTH, etc., etc. There will be mild variation. But in case of CKD MBD, it is complicated. There is significant variation of the calcium, phosphate, parathormone, vitamin D, alkaline phosphatase, etc. In osteoporosis, there is no such extraskeletal calcification which increases the cardiovascular morbidity mortality. But in case of CKD MBD, there is increased chance of getting the extraskeletal calcification, there is a cardiac calcification, and so the chance of getting cardiac disease is very, very high. So this diagnosis and management of osteoporosis in CKD is very, very important, because as the ESRD increases, the chance of getting fracture is high, and as the age increases, the ESRD increases. So this is interrelated. But the challenges are, the assessment of fracture risk and osteoporosis in CKD is very, very difficult. It is not straightforward like in case of postmenopausal osteoporosis. Just do DEXA scan and you can find osteoporosis. Here you have to assess whole spectrum, and after that you have to go for DEXA, and then you have to assess the osteoporosis. And second is the management of osteoporosis in CKD is again very, very difficult, challenging, that will come. So in case of CKD, you have to go for assessment of CKD MBD plus osteoporosis. So what are the modalities? Modalities are the calcium assessment, the vitamin D assessment, PTH assessment, and the bone turnover marker like CTX, P1NP, etc. And there are bone osteoporosis measurement like DEXA or CT scan. And there is a combined or the combination method, this is called FRAX score, along with the history and others. So these all can be incorporated for assessment of osteoporosis in CKD patient. And what is BMD? It is nothing but the bone mineral content of a particular bone. I'm again not going in detail, but T score is very important, as it is T score which defines osteoporosis. So T score means it is a particular amount of bone you have when compared with a young adult of 30 years old with the same gender, with a peak bone mass. So with that you have a T score, and Z score is in the same age group. Now with this T score, we have a definition of osteoporosis, that is by WHO. When the T score is below -2.5, it is called osteoporosis. When it is -1 to -2.5, it is called osteopenia, and 0 to -1 is normal. So when it is -2.5, this is osteoporosis. This is actually a straightforward diagnosis by DEXA scan in postmenopausal osteoporosis. So that is there. But in case of CKD MBD, you have to have a different combination. So that is the change that happened in 2017. Earlier, the concept of CKD was, that the only when you find that calcitriol is given in the prescription, it is nothing other than CKD management. So that all are changed now. So since 2010, 11, 12, we have lots of paper that have identified that the assessment of DEXA scan osteoporosis in CKD population is actually significant. And since then the concept changed. In 2017, KDIGO told that you have to go for DEXA scan for osteoporosis assessment in CKD population if it modifies the particular therapy and the quality of life. So this is the milestone in 2017 that achieved, and that is the awareness started to grow for the development of osteoporosis, detection of osteoporosis and their management of osteoporosis. So next comes the risk of fracture score, means fracture risk assessment combination method. That is FRAX score or the FRAX tool. Again, I am not going in detail. FRAX tool is available online or offline. You can download anywhere in your computer or in your mobile, and there different parameters are there like age, sex, weight, height, previous fracture, parent fracture, hip, current smoking, glucocorticoid, rheumatoid arthritis, secondary osteoporosis, alcohol or more use per day, femoral neck, etc. Now after that you can have the data, and with that you have a risk factor assessment score. So with that NOF guideline is there, where it is told that if it is more than 20% of risk, then it is a major risk factor, and if it is a more than 3% hip fracture, then it is a significant risk factor for osteoporosis in particular patient. With that, you can have a good assessment of a prediction of fracture due to osteoporosis both in CKD, MBD as well as in the normal population. So this is another very important basis, that you have to use this FRAX score for assessment of fracture risk in a particular population. Now coming to renal disorders and the burden of osteoporosis. So as osteoporosis and CKD are more prevalent with aging, so you have a more and more osteoporosis in older age group population. This is very easy calculation, is a directly proportional. But the cause for this reduction in the bone strength in CKD are multifactorial. Particularly, it is the reduction in the 125 diagonals of vitamin D. There is the active vitamin D deficiency is there in the early stage of the CKD, and as the CKD advances, there is more and more deficiency of this active vitamin D. And there is increased PTH, and so there is a high turnover bone disease along with this low active vitamin D. So there is increased turnover and there is increased fracture risk, and there is abnormal mineralization. In post-transplant osteoporosis, again a very important risk factors because of the increased burden of steroid as well as the previous burden of CKD osteoporosis before transplantation. So with that, you have bone disease, you have to go for teriparatide, anabolic therapy. And in case of normal turnover, in that case, it is very difficult. You have to go for bone biopsy to find actually what is happening inside the bone. And depending upon that, either you use antidisruptive or the anabolic therapy. This is in a nutshell the therapy. The problem is here. The therapy that is available in osteoporosis treatment, like these phosphonates, is very difficult to use in case of CKD because there is a high chance of getting more and more CKD. There is a risk factor of worsening CKD. There is increased chance of jaw fracture, osteonecrosis of the jaw. There is chance of getting hypersensitive reaction. There is high chance of getting low turnover bone disease by using these bisphosphonates. So bisphosphonates are not safer or very difficult to use because less than 30 GFR you cannot use bisphosphonate. Next, the parathormone. The parathormone problem with the parathormone is that there is high chance of hypercalcemia, and with that hypercalcemia the patient may die, or patient will have more and more kidney failure. So again, it is not safer to use this parathormone in case of CKD, MBD. So what left? No other options available till the availability of one particular molecule that is came up. It is called denosumab. This denosumab has changed the paradigm in the management of osteoporosis in general population as well as in the CKD population. So this denosumab is nothing but a fully monoclonal IgG antibody. It is rank ligand. Again, I am not going in detail about this rank ligand. What does rank ligand do? It actually decreases it increases the activity of osteoclast so that the bone resorption does occur. Now, if the rank ligand can be inhibited by this denosumab, then this activity of osteoclast will be prevented, and ultimately the bone resorption will be prevented. And so this is the actual therapy. So this is a actual remarkable change in the therapy for the osteoporosis. So here is the denosumab. The denosumab can be used in case of postmenopausal osteoporosis, can be used in case of glucocorticoid induced osteoporosis, can be used in case of male prostate cancer like therapy when you are using, then osteoporosis you can use this in this particular patient, and in case of CKD, MBD where osteoporosis where no other therapy is actually safer. The dose is 60 mg every 6 monthly. You can use up to 10 years. Contraindications are hypocalcemia, pregnancy, and known hypersensitivity. Clinical evidence, again, I am not going in detail. This is a freedom study. It is the largest ever study with 8,000 odd patients, and they initially took for 36 months. then it is extended up to 10 years. And there it is significant improvement in the new vertebral fracture. There is 68% risk reduction in the new vertebral fracture, 20% reduction in the non-vertebral fracture, and 40% reduction in the hip fracture. So this is a significant improvement in the risk factor reduction. So, and this actually continued till 10 years that the therapy was given. But one consideration is when you stop this therapy, immediately within the first 6 months to 1 year, again there is a increased chance of getting fracture because of the decreased bone mass. So this is another very important aspect. After stopping this denosumab, you have to use another therapy so that the patient should not get fracture post stoppage of the denosumab. Now these are the different agents that we can use in CKD, but these are not safer. I am not going detail. This denosumab was tried in dialysis population, in post-transplant population, as well as real life in CKD non-dialysis dependent population. And each and everywhere it was shown that this denosumab is number one, it is safer, it can be used in case of dialysis patient where it will not induce high turnover to low turnover bone disease. Actually it maintains a good turnover bone disease when bone, and it makes a bone strengthen more than if you use other agents like zoledronic acid or other bisphosphonate and other agents. So this denosumab can be used in case of dialysis patient safely, in case of pre-dialysis CKD patient, advanced CKD patients safely, and in post-transplant CKD patients. And if you see, I am working in this denosumab molecule in our department. We have just completed a 1-year thesis on that, and we have got a 10 patients data of 1 year. Now it's more than 1 year. There is a significant improvement in the DEXA scan. Number one, within 1 year of therapy, there is significant reduction in the dose, in the risk reduction of the osteoporotic fracture in 1 year period, and there is no such adverse events that happened throughout this 1 year period. So denosumab can be a game changer in the treatment of osteoporosis, both in the normal population, postmenopausal osteoporosis, as well as in case of CKD osteoporosis treatment. So I am concluding by giving this take-home message that number one, osteoporosis diagnosis and its management is critical but difficult issue in case of CKD. Denosumab will be the drug in treating osteoporosis in CKD patients, but it needs more studies to confirm its effect on bone dynamics or turnover, as terms of dynamic bone disease is a theoretical possibility. Thank you. Thank you for patience here.